Hello, everyone. I would like to invite you to our first inaugural session on lysosomal disorders. We are Lysosomal and Rare Diseases Research and Treatment Center, a nonprofit organization. So we want to start from the very beginning for this particular meeting, from the newborn screening. So my question is, are the lysosomal disorders ready for newborn screening? The reason is many disorders are still, they don't have effective therapies, unfortunately. Yes, the answer for that. The reason is neonatal screening or newborn screening is beyond treating patients with treatable forms of therapy. However, it brings many advantages, including early diagnosis, that open the avenues for research, and also actually brings the family to conclusion and getting ready for the baby. But what is most important among all is that it provides equity for all children who are born to get a diagnosis, management, referral, and when the treatments are ready to get the treatment. So however, newborn screening is an arduous process. So whenever the decision is made whether a disease is appropriate for newborn screening, it takes many years to get it from the idea to the patient. So we want to actually provide you a glimpse of this journey with our 4 exquisite speakers. That is what it entails when a newborn screening is started in a state. So our first speaker is Amy Gavaglio, and she's going to be presenting the process of RUSP and how do we get from RUSP to the patient. And she is the primary and also the founder of the Kinetics Consultancy, yes, exactly. Our second speaker, Dr. Gustavo Magueva, is from Columbia University Irving Medical Center, so he's going to take over and we'll discuss the laboratory technical aspects of newborn screening. And then Dr. Krohn, who is serving as the section chief for medical genetics at the Valhalla Medical Center, which is designated by the New York State as a specialty care center for newborn screening referrals, will actually describe the after they receive a newborn with a screening positive results, how you get the actual diagnosis. And finally, Ryan Coburn, who is not only a patient advocate, but also the principal of a company called ODIM that actually stands for One Day It May Matter, will take over and describe what do we do with this big data. Thank you very much, Amy. Please come. And before actually Amy starts, so I will show the learning objectives, also disclosures. At the end, we'll have a Q&A session. We're not going to stop. It's going to be old school microphones, so take it over. Thank you.
Thank you. So my job this morning or this afternoon in starting this session is to hopefully set the foundation for the rest of our speakers by providing a brief background on what newborn screening is and what the system looks like. Then we'll talk a little bit about how diseases are actually added to the Federal Recommended Uniform Screening Panel, or RUSP, here in the United States. And then I'll end talking a bit about what implementation needs to look like at the state level in order for newborn screening to meet its goal of successfully and, most importantly, equitably meeting or improving and maximizing health outcomes for all children and families who have one of these diseases. So I always like to start, as I talk about newborn screening, with this slide as a foundation to remind us that newborn screening is not diagnostic testing, it is a risk assessment. And so what we do is we take a seemingly healthy population of newborns in the United States, that's about 3.8 million newborns. We apply biochemical or molecular analytical tools to assess whether we feel that this child is at higher risk of having one of our diseases, those are illustrated in orange, versus those that are lower risk of having one of the diseases who kind of pass through the screen, those are illustrated in green. Any child that is found to have a positive or at-risk screen needs to go on to have further testing, diagnostic testing, or confirmatory testing in order for us to determine, yes, this child is affected and needs further management and treatment, a true positive result, or that child is unaffected or a false positive result and can be released from care. Because we are talking about screening, we cannot forget about the children who pass through the screen, those negative results. While the vast majority will be truly unaffected or a true negative result, because this is screening, false negative results do exist, so there may be children who are not picked up by the screen, and so we must always remind clinicians that clinical vigilance is important even when screening exists. So some very quick background on newborn screening that will help set the tone of this program. So first and foremost, newborn screening programs are public health programs. This is unique in that this program has really based itself within the public health sphere. However, successful programs do require knowledge and coordination from multiple partners, and I think you'll hear that with the remainder speakers. Newborn screening programs in the United States are state-based. While we do have the federal recommended uniform screening panel, the key word there is recommended, not required, and so it is up to each state then to determine how, when, or if they will actually begin screening for this disorder. Newborn screening programs in the United States are also quasi-mandated or opt-out programs, which means that the default is for newborn screening to occur. We do not get overt informed consent for this program, and this is helpful, I think, in understanding how important it is if we are choosing to mandate something that we have the infrastructure in place throughout the entirety of the system for these families. And newborn screening programs are designed primarily to treat treatable conditions or to detect treatable conditions, and we'll talk a little bit more about this as we talk about the RUSP process. So on the last slide, I mentioned how important it is that successful newborn screening programs bring in a number of partners in order to successfully and appropriately manage these cases. And so this is just a schematic of how these individuals span a gamut from the health department to the clinical team to, of course, family support and resources, quality assurance, technical support, research, policy, ethics, and advocacy. So newborn screening, as many of us know, began in the 1960s and sporadically and kind of haphazardly began to expand, really leading to some pretty disparate numbers of disorders being screened for state to state. So much so that in 2000, the AAP, the American Academy of Pediatrics, really called for a national or federal guidance in trying to get uniformity across the United States for screening. This ultimately led to the formation of the Advisory Committee on Heritable Disorders in Newborns and Children, which I will only be saying once because it's a mouthful, and now we'll be referring to it as the ACT-DNC. And it is this group that is currently responsible for developing and recommending diseases to be on that recommended uniform screening panel. As of this year, right now, currently 8 diseases have been added to this RUSP using this ACT-DNC mechanism. So what is this committee exactly? So this committee is made up of individuals who have been appointed by the Secretary of the U.S. Department of Health and Human Services to advise him or her on the most appropriate application of universal newborn screening test technologies, policies, guidelines, and standards. It's currently made up of 8 non-federal members, as well as 5 ex officio members, all of whom represent the federal government, think CDC, HRSA, FDA, NIH, and the like. These members are the voting members. And the committee is also made up of a number of organizational representatives who are allowed to provide comment and insights, but do not actually vote as part of the committee. So this highlights what the RUSP process looks like. What I really want you to get from this slide is that this is a very intense, multi-step process in order for a disease to be added to the RUSP. So first, the nominator must submit a nomination package. This is a pretty robust package that highlights that a test is available, that treatment is available, that treatment is efficacious, and that it needs to be administered pre-symptomatically. A subcommittee of the larger committee will look at that package and determine whether or not they think it warrants further review. If they do think that that is the case, after a vote of the committee, it gets sent on to what we call the full evidence review, which is a 9-month process where they will assess both the peer-reviewed literature, often gray literature, and then again make a vote on whether or not they feel like it meets criteria for a mandated population-level screening program. I mentioned a period of 9 months. Please know that this entire process takes years and years, from evidence generation all the way to when the secretary actually responds. So the purpose of the RUSP was to work on national harmonization. And so the question remains, has it been successful in reducing screening discrepancies in this country? And I can pretty definitively say yes-ish. It's better, but you can see from the map that there are, 50 shades of green, essentially, and so you can see that there still remains quite a bit of disparities among states in what they are screening for, again, owing to the fact that that is done at the state level. Quickly, the RUSP is actually made up of 2 lists. We have our core conditions, which are those that typically have gone through that process and meet all of the criteria. Currently on the RUSP, there are 37 core conditions. And then we have a list of secondary conditions. These may more commonly be thought of as maybe incidental findings. We are not targeting or trying to find those, but in the process of our screening, we may pick them up. Think XALD is our target condition. A core condition or a secondary condition might be Zellweger syndrome, as an example. This is a highlight of the key conditions or questions that are considered by the committee. And if you are familiar with the Wilson and Youngner criteria, you'll see that these align very much. So the condition must be serious. We must understand the case definition and natural history of the condition. We should have a test, we should have treatment, and we need to have some prospective pilot data. That is a requirement as of right now. So many programs and many advocates, their goal is to get a disease on the RUSP, which is absolutely a laudable and important goal, but it's only the first step. Now, once you have a disease on the RUSP, we have to really look at how do we actually get these babies screened, which is truly the ultimate goal here. So I'm not going to go through this in the interest of time, but just to indicate that at a state level, there are a number of phases and needs that need to go into effect in order for a state to actually begin universal screening. This spans the gamut from getting the money to do it, hiring people to do it, validating the test within their laboratory, making sure that clinicians are ready and prepared to see these children and their families, developing education materials, integrating data, understanding what data we're going to be collecting and need to collect in order to show that we're doing what we need to do. And then after implementation, also assessing the impact at a public health level. So I want to end before passing on to our next speakers and really highlighting again the fact that newborn screening is a system. And I think when many of us think of newborn screening, we think of this. We think of the test itself, we think of the results, we think of the immediate diagnostic testing saying, yes, this child is affected, or no, this was a false positive result. But it is so much bigger than that. We have to start thinking about these diseases in education in the prenatal period. We have to start thinking more about what is needed after these children or families are diagnosed. Our management and treatment guidelines are very different for these individuals from those that have historically presented clinically and later in life. And ongoing transition to school, transition to adulthood, and then the circle comes kind of full circle at that point. So I know our remainder speakers will talk more about the lab pieces and the management pieces and the data pieces, but I want to highlight one piece that I think often we forget about in newborn screening, and this is the communication of the result to families and really setting them on this new journey. So in the interest of time, again, I'm not going to read through these quotes. These are actual quotes from families who have received positive newborn screening results, but I will highlight a few things. So the first, you'll see that someone said, we went on Google. Please never tell patients to not Google it. That has a success rate of 0%. Please. You'll also see words like trauma. You'll see words like we were alone, we weren't given the support. And so I want to really reiterate how important it is for us to, as we think about newborn screening, not forget about that initial point in time when we set these families on this new journey. We have developed some communication tools that can help with this. I just want to highlight how important these are. The one on the left is more disease focused. It talks about the disease itself. In this case, it's MPS II. The one on the right really tells providers how to provide this information in an empathetic and supportive way. So I think with that, I will turn it over to our next speaker to talk more about the lab portion of newborn screening. Thank you.
Good afternoon. I'm assigned to talk mostly in the technical aspects of the newborn screening. In terms of newborn screening methods, I'll go over the utilization of tandem mass spectrometry in the newborn screening programs and the stepwise approach to the laboratory diagnosis at the newborn screening level. And then further applications in the newborn screening approaches and methods, and then summarize some techniques used in different states and countries. So the newborn screening, as was said earlier by Amy, is a health problem, but it initially was a practitioner a Norwegian practitioner who was seeing a family of 2 siblings who had mental retardation. And basically in Norway, he used to do a lot of tests for urine. And one of the tests used at that time was ferric chloride acid to be added to the sample, the urine samples. And here is a very different color in which we see a very dark blue color, which alludes to the abundance of phenylpyruvic acid in the urine sample. And that was individuals or children with phenylketonuria, or PKU, which was the first newborn screening assay developed for a newborn screening based. And those are the awardees of the Joseph P. Kennedy Foundation Award. And at that time, Ivor Cullen was one of the awardees. And he basically was awarded with multiple people like Joe Tijo, Jerome Levad, which was one of the ones that discovered the chromosomes. But not until Robert Guthrie actually developed an assay, and he was studying a lot of nutrition and developing analogs of different amino acids. And one of the amino acids was beta-2 thioalanine, and that specific amino acid basically could inhibit the growth of bacteria, a specific bacteria, Subtilis, in growth. But in the abundance of phenylalanine, that bacteria could overcome the growth, and then, as here pointed out with the arrow, you can see the overgrowth of the bacteria, which was used as a diagnostic tool to basically screen babies with phenylketonuria. That was the first newborn neurogenetics or inborn error of metabolism screened on a population base through dry blood spots. Then, obviously, he developed and expanded to multiple states. The relevance of the historical endpoints is that the assays were developed in the 60s, but not until the late 60s, the newborn screening was applied in a populational-based assay, thanks to Robert Guthrie assay, and was a unique perspective in which you could modify the nurture to kind of treat the nature of individuals with deficiency of phenyl hydroxylase. But over 30 years, that hasn't changed. So until the development of different techniques to assay different metabolites in the dry blood spot samples, and until then, in the early 90s, with the advent of a multiplex testing, which basically applies the tandem mass spectrometry to basically do 2 different assays, the amino acids and acylcarnitines, and through which we can detect and diagnose over 30 different genetic disorders. And that basically was quite an advance, because you could identify babies and treat them earlier before they become symptomatic and with irreversible changes, mostly neurological changes. So Pompe and MPS I, or mucopolysaccharidosis type 1, were the first newborn screening lysosomal diseases to be recommended for RUSP, and then given the outcome of promising therapies for those two disorders. But the technical approaches started with the current, or the diagnostic assay that was used to diagnose individuals with different lysosomal diseases, using a 4-mu substrate assay, and which could eventually be assayed from specimens or samples from dry blood spots. And however, this was a little cumbersome because the time of incubation was kind of 18 hours and kind of long. But with the digital microfluidics with fluorometry, which is DMF, here spelled out, can be used to simultaneously diagnose 5 different lysosomal diseases, or assay 5 different hydrolases. It's a spatial multiplex assay in which a specific device simultaneously you can measure the activity of 5 different or 6 different lysosomal assays over a short period of time at a lower cost. So it's still a biochemical assay used to be read in a specific multiplate fluorometric apparatus or equipment. In terms of the mass spectrometry, it's still an assay based on the lysosomal enzymatic activity using specific substrates, and then resulting in a product through which we can measure using mass spectrometry. The mass spectrometry, what it is basically an equipment that breaks down fragments, a specific molecule, and generate ions that are basically run and guided through electric or magnetic field, and can be basically generate different fragments of the ions and then detected through and distinguished through a mass charge ratio. Here is just a chromatogram showing a molecule that was broken down in different fragments, and then you can take one of those ion products or daughter ions and then create a specific reaction through which, having the specific standards, you can quantitate based on the area of the peak of a daughter ion from a specific metabolite. So that can be used very robustly with very high sensitivity and specificity to diagnose at a newborn screening level some lysosomal diseases. But they're used, and there is a lot of members probably here in the audience who helped to develop assays. The first one was Gaucher, that was implemented in the New York State thanks to the work of Michael Gelb and his group, developing substrates to specifically through the products of those substrates being detected through mass spectrometry. And the multiplex assay is now popular and can be assayed 5 or 6 different enzymes at the same time through the detection using mass spectrometry. It's important to know that there is another equipment associated with mass spectrometry called LC or UPLC, which is basically separating further the molecules before injecting to the mass spectrometry. So here is a kind of workflow difference to summarize the techniques. In the upper row, we have the enzymatic assay using the digital microfluidic or MF, microfluidics fluorometry. And the assay can be robust to diagnose or basically screen for MPS I, Pompe, and Gaucher or Fabry disease. And the incubation time is relatively short, less than 3 hours, and the sample and the assay can be extremely flexible. Then the mass spectrometry, there are more lysosomal or hydrolases we can assay from a dry blood screening specimen. And it's also flexible, and depending on the enzymes, the incubation time will be different. But they can assay at the same time and then run in a single run in the mass spectrometry. So those are the two approaches now available. The tendon mass spectrometry or liquid chromatography, if you do use it, in the New York State, you can diagnose or screen for different MPSs, MPS II, MPS IIIB, 4A, 6, and MPS 7. The lysosomal sulfatase assays can be done, and however, there is a trick and the importance of using a specific LC equipment before the mass spectrometry injection to basically avoid the accumulation of sulfatate products in the ESC source. It's a prolonged incubation if you need to include the Gaucher assay, which requires 17, 18 hours incubation. The microfluidics is also flexible, but can be a shorter time, but obviously if you incorporate Gaucher, it will be a little longer time. It requires the specific channels to separate the substrates, the different conditions for each enzyme, but can be done in a single device or plate. What I'm showing here in this slide is the different types of approaches or assays using mass spectrometry at different states. That basically most of them are using mass spectrometry method, using specific substrates that are amenable to, through products are amenable to be detectable through mass spectrometry. And here for MPS I, hyaluronidase, it's extremely popular, the mass spectrometry as a methodology to screen for newborns for different MPSs. And here the upcoming methods coming along for different lysosomal diseases through mass spectrometry and DMF as well. And the only state, as far as we know, doing DMF now is Missouri. All the other states in the union are basically screening for mass spectrometry. And so in summary, we have mass spectrometry and digit microfluidics fluorometry as platforms for screening of samples coming from dry blood spots for different lysosomal diseases. Since 2013, Missouri has been using the digital microfluidics to specifically diagnose 2 different lysosomal diseases. Both methods are flexible, expandable, and can be run in a throughput fashion. In the mass spectrometry, obviously offer a better sensitivity, detects a specific natural substrate eventually that can be eventually be used for monitoring treatment. For instance, sulfatides, sphingolipids that eventually are increased in the dry blood spot and eventually can be further optimized as a biomarker. So this is my group, and we do also research developing biomarker discovery in LSDs. Thank you very much for your attention.
Okay, so thank you for that. And I'd like to move forward in talking about how we actually manage patients with the disorders. So, of course, this is a very important slide, and we just had the introduction to Robert Guthrie, looking at the bacterial inhibition assay plate. So we need to remember what is newborn screening. So it's early diagnosis, intervention prior to onset of symptoms, and prevention of disease progression. And this would be the mantra for newborn screening, and it applies particularly to PKU. And we still use the same Guthrie card that was the filter paper card. It's still used from 60 years ago, and it can be used not only for the enzyme assay, but also for molecular diagnostics. So that's really important to consider. The other thing that's important to consider is that the LSDs add a different complication to newborn screening in that many of the diseases are late onset, and that's something that we need to consider. It's also, before the RUSP in 2005, there was a survey of diseases which should go on newborn screening. And at that time, if you look right down at the bottom here, at the very bottom, sorry. Yes, with this here. So here, right at the bottom, this is where the LSDs were at that time, Pompe disease, Fabry disease. So we hadn't, at that time, because we didn't have the technology, we didn't have the full treatments that we have now, it wasn't considered as good candidates for newborn screening. That's all changed. So, we now have better treatments, which you're all aware of. Enzyme replacement therapy, bone marrow transplant, gene therapy, of course, is on the pipeline. And so the improving responses to early treatment is something that we know about. So we do know now that the earlier the patients are identified, the better the outcome of the treatment. And so they become candidates for newborn screening. And as you can see, there's more in the wings at this time. So as we know, on the RUSP, we have MPS I, MPS II, and Pompe disease. Krabbe disease is about to go onto the RUSP as well, and there are many others which are potentially going to add in the next few years. Just to remind you how we see patients, so patients are referred, and what happens is that if a screen is mildly elevated or low level actually of enzyme activity, then a pediatrician will get a call and the sample will be repeated. If it's a very high level or a very low level, then the sample could be actionable and will be referred directly to the center for evaluation. Because there are so many diseases that are being evaluated at this time, there's about a 10% repeat samples are being required. So that's an important consideration. So it is a process which Amy laid it onto. And one thing that's important in newborn screening is the timeliness of the samples. So now it's recommended that samples be collected at 24 to 48 hours of age, and that's really important. And actually, that's important if samples are drawn too early, there's a risk of maternal effects, and the enzyme assay may be too high, and you may miss a case. So it's actually important that samples are drawn after 24 hours. It's also important that the samples are delivered to the lab very promptly, and so they are couriered in New York, and that there's timely reporting of the results. So usually we have reporting at about 5 days to 7 days of age in New York. This is something that has to be considered in the process, and there has been some delays with the LSD patients that has been reported from some states. So that's something that we have to work on. So also, the case definition is a little bit tricky with these diseases. So we've had quite some difficulty because a lot of the patients are asymptomatic at the time of initial diagnosis, and this is particularly with Pompe disease, where there are a lot of patients who have been classified as at risk for Pompe disease. They may not have pathogenic variants, or they may have one pathogenic variant and a variant of unknown significance. They may have no clinical symptoms, the biomarkers may be negative, and so it becomes difficult to classify patients very early on. Obviously, the role of newborn screening for Pompe disease is, of course, to pick up initially the patients with the severe infantile onset Pompe disease, but it's turning out through screening that LOPD is actually turning out to be quite common or at risk for LOPD. So it's something that has to be considered. So in New York, the initial sample will have a second-tier test. So a sample that's actually flagged will have molecular technology. So we'll have a variance will be detected early on. This is not always the case in every state, so there can be delays in defining a case because once the patient is seen, a sample will be sent for molecular diagnostics. So it's always important when you have a newborn screening to check on the status of the patient. They can be sick at the time of the referral, so we may need to bring them into the emergency room. So that's very important to be aware of how the patient actually is doing. So when we bring a patient in to be seen, it takes some time. A full evaluation of a patient coming in for newborn screening can take at least 2 hours. The patient comes in, the demographics, they meet initially with a genetic counselor, they go through all the findings, the prenatal history. Then, depending on what we suspect based on the result of the initial test, if it's something that we suspect has the disorder, we may have them meet with the nurse practitioner from the LD program. It depends what is going on. But we have to be prepared for these patients. So that's important. So we have actually developed algorithms and actually cheat sheets for the nurses to be aware of and how to act when they see a patient, because I think you need to be prepared for these patients. You can't do it on the fly. We also, for Pompe disease, we have worked with cardiology, and these patients are seen by cardiology on the day that we see them. So it's sort of a seamless process. So looking at Pompe disease, we had earlier developed this algorithm, and so in New York, we already have the variants described, but what has to be done is obviously define what you're dealing with in terms of the patient. So if you have two pathogenic variants and the patient has evidence of cardiomyopathy, then you probably have a patient with infantile onset Pompe disease, and that's the patient you may want to treat, depending on how they are doing. Of course, if you don't have cardiomyopathy and the patient is stable otherwise, but you have, for instance, a pathogenic variant and a VUS, then you have a it becomes quite difficult at that point to decide whether this patient is somebody who's really at risk for LOPD or not. So we'll have to go into long-term follow-up. So this is something that has to be considered, because here we have a situation where we have patients who do not have disease at the time of the diagnosis through newborn screening, but may develop disease later on, so disease in waiting. So this is something that we have to be very aware of, and how we're going to follow up these patients to make sure they're not lost to follow-up. So when we get a referral for Pompe disease, for instance, we try to see the patient within 24 hours, hopefully on the day of the referral. We arrange for the echo to happen on that day as well. And if the echo is abnormal, depending on the variants that are detected, we may admit the patient to the hospital so that we can start evaluation for treatment. Or if the cardiac evaluation is negative, but we are very suspicious, we may recommend an appointment in 2 weeks where we may repeat the cardiac evaluation, depending on what's the status of the patient. So we always have to be prepared for the unexpected. Some of the first patients that referred from newborn screening, we thought they were LOPD, but actually, in fact, after a month, the patient started developing cardiomyopathy and was reclassified as IOPD. So that can happen, and so the natural history of the disorder with infantile onset Pompe disease is being redefined because of the diagnosis through newborn screening. So something that we need to be aware of, that what we think of the diagnosis can change. It's very important to be in communication with the parents, and that's something that's really important, because we have to have them to buy in to the fact that the child may be asymptomatic, but may develop disease later on. And so we have to keep them engaged. We partner with the pediatrician in the local area to make sure that they actually stay engaged, because we don't want to over-medicalize them, but we also don't want to miss a patient. And this happens also with MPS. So it's something that we think about quite a lot of. So and this is where it's important to spend quite a lot of time with the families, because the patient has been diagnosed potentially with late onset Pompe disease. They may or may not actually develop disease. We don't know, because we do not have a full natural history at this time of what will happen when the patient is diagnosed through newborn screening. We have to be clear about how we're going to follow the patient so that they have their expectations are met. And if there are changes in biomarkers or changes in the clinical status of the patient, then we have to be able to act accordingly. So that's something that we have to be the parents aware of, so that they will come in when they need to. So, in the first year, it's a little bit complicated. We may see the patient every 3 months. We may see them more frequently, depending on what the initial testing showed. If the patient is stable after the first year, we go to probably every 6-month follow-up with HEX4 and HEX and CPK. And if there's a concern with arising biomarkers or anything like that, then the patient will be brought in more quickly. Maybe we will do the biomarkers every 6 weeks or so, just to make sure that we don't miss an opportunity to treat if there's a change in the patient's status. When the patient is older, we will consider starting pulmonary function tests. And also we do try to get a physical therapy evaluation at least around the first year of life. With MPS I, the alpha-L iduronase deficiency, that also has been added to the RUSP, so we are getting referrals. Interestingly, we actually haven't diagnosed a patient at our center yet. All the patients we've seen so far have had pseudodeficiencies. So it's important that, here's another algorithm for MPS I. So it's important when you see the patient to actually measure GAGs, because that helps to differentiate the patients who may have a pseudodeficiency allele. And of course, if you have a known pathogenic variant, then obviously, and it's an early sort of Hurler phenotype, then we obviously refer the patient for evaluation and possible bone marrow transplantation. So that's very important. So it's very important, again, to stratify the patients and be able to work with them closely. Similar algorithm also is for MPS II. This has just been added to the RUSP, and we started screening for that in New York in the last year. So just a reminder about the pseudodeficiency alleles. It's a mutation that changes the protein expression, but without causing disease. And it's quite common in LSDs, so just to be aware of that. And that affects the diagnostics following newborn screening. So we ideally contact patients as soon as possible once we get a referral, and we do have established protocols for families. So just the last couple of things. We don't know the latency for some of these disorders, and that requires making sure the patients are engaged and the families are engaged. And there is a risk to follow up, and that has been a concern. We sort of have to be prepared for the unexpected outcomes. So finally, the newborn screening is the largest public health program. It affects more than 4 million infants annually, and it's a large group of heterogeneous disorders. Now that we have many treatments available, it becomes more important to be aware of these disorders. Many more will go on newborn screening in the next few years. Of course, there's gene therapy in the pipeline. And remember again that the screen is not a diagnosis. The patient must be seen first. Thank you.
So we've heard about newborn screening, how it works, how the lab part works, and I'm here to talk about some of the utility of newborn screening beyond saving the lives of newborns today, and how that can contribute to preserving life tomorrow. So newborn screening is the coolest game in town. Universal screening programs in general, which are available across populations, indiscriminate filter criteria such as socioeconomic, race, pre-existing conditions, et cetera, help to address inequality that exists in public health. And when that screening is done in a timely reference frame, for example, at birth, that provides an opportunity for improved health outcomes for each of those individuals, families, and communities. So below here, we have some quick comparison figures from the MPS work in Pompe. First is a quick status check that we have 87% of US births currently occurring in jurisdictions that have a newborn screening for Pompe, with line of sight to 97 by the end of the year. So we're doing pretty well there, but we're only at 3% of worldwide births, so there's a lot of work to do. The next is a view of changes in diagnostic yield. So before newborn screening, we can now show that we're about 3% good at diagnosing Pompe disease. With newborn screening, we're greater than 90% good at diagnosing Pompe disease. The impact for the severe end of the spectrum is really quite obvious. We've had 90% plus mortality within the first year of life if you don't have timely access to diagnosis and treatment. Versus 100% survival and quality survival in the newborn screening realm. For the spectrum more broadly, we have a minimum of 37 years and a lower bound of 37 years in the US and 30 years worldwide for people that are waiting for a diagnosis. So this is the diagnostic delay. So newborn screening addresses that. And when it's done timely, of course, in newborn screening, it enables proactive management. And some of the studies that we're learning from the work coming out of newborn screening is that there's actually no such thing as asymptomatic or patients in waiting in Pompe disease. And that makes sense, right? The screen itself is detecting metabolic dysfunction from the very beginning. And so it allows us to develop a strategy for when the threshold of action should take place. And as a teaser for the next slide, we've got some epi conclusions that we can move on from. That in the pre-newborn screening world, we had an idea of what prevalence was. We had an idea of race-differentiated prevalence and a fraction of severe cases that we now know to be wrong. So the title of this work by Groft and De La Paz says a lot, and we've grabbed some key points from the work. That in the rare disease community, we suffer from the absence of reliable epidemiology on prevalence and incidence of rare diseases, and that has a huge amount of ramification in global populations. And so this reliable epi allows us to move from these ideas, these myths that are based on sort of limited information, and move into to new scientific realities. And so we need to kind of pay attention to these kinds of efforts. And the point of this is not to discourage work in areas that we don't have strong epi. Rather, it's to remind ourselves of the importance to hold space for evolving conclusions as new information becomes available. Newborn screening does this in an obvious way for the conditions which it exists, but what is less obvious is it may be really helpful for improving epi beyond conditions which have newborn screening. So to provide an example of this in practice, we can take a look at 4 studies on the prevalence of Pompe. And with hindsight, we can go back to these studies and adjust some of the assumptions made in those studies to change the conclusion, to get them more closely to what we now understand to be the prevalence. But that's kind of cheating, and it's not really the point. The point is, again, demonstrating this idea of acknowledging uncertainty and conclusions that are drawn, and making sure that the strength of those conclusions that we hold are in the context of their inputs. Sort of more simply, along a learning journey, conclusions of large uncertainty with large uncertainty inherent are really important, but we should write those things in pencil and not etch them in stone. To kind of continue this narrative, on the right side, we highlight the evolution from what Groft and De La Paz would deem as myths into realities as we go top to bottom, and I'll have a visual for this in a second, so it'll make more sense there. And highlighted on the bottom is this observation that yields the hypothesis that newborn screening may be incredible for genetic conditions beyond those that have newborn screening. So we're all used to seeing confidence interval as a measure of uncertainty, and if you're a real nerd, and I say that like very endearingly because I know what my reflection looks like, you remember that confidence interval is really looking at type 1 error or alpha error. And the typical setting for exposure to this type of error is 5%, which leads to our beloved 95% confidence interval. Power analysis adds coverage for type 2 or beta error, which for simplicity adds a dimension of rigor when looking at uncertainty. And I really, really encourage everybody to start asking for power analysis to be done more often, because there's a really good insight that we get from it that we'll show here. So on the left are the power curves from each of those 4 studies with the alpha error set at 5%, and the red goalposts are showing what the 80% power levels are. Note each of these power analyses are run with only information that was available at the time of the study, and on the top row, the x-axis is about 20x zoomed out just to fit in the level of uncertainty that compared with the bottom row. So on the right, we have a visual summary of this, where the red dot and whiskers are the prevalence figure, the point value, along with the 95% confidence interval uncertainty, and then the blue dots are those same point values, but with a power analysis range thrown on there. Yeah, and so the differences are really, really quite dramatic. With the 2 studies on the left, which have really set the context of everything that we know about Pompe, or have studied in people with Pompe over the last 25 years, they haven't been any more precise than to be able to say that somewhere between 0 and 450 kids out of every million are born with Pompe. On the right, we get far more precise, and that's really cool. So what is so cool about that? In the rightmost set of dots there, it's a newborn screening direct method for determining prevalence. And so there's enough data behind this to be considered as a reference of truth. And so it's really clear we should just do this for every disease, and then we'll be in really, really good shape. But we learned from Amy earlier that adding a newborn screening condition, even once we've already kind of hit these other milestones of understanding, is not particularly easy, and there's decades of effort that go into that. So waiting decades for each condition is a really bad idea, but the second rightmost study by Dr. Park in Korea is based on publicly available genetic data set, which is continuing to grow, as we know, and it's getting closer and closer to our reference of truth. And we can quantify that closeness. So this offers the hypothesis that we can quantify that closeness as a grade of goodness of the ability for such data sets to answer other research questions. So as we look at other newborn screening data sets that converge on references of truth, we might be able to use those to validate broad data sets to answer other questions. And this is one idea for how we can go much faster. So in my world, coming from processes, we recognize heredity as a process for our species. In this case, humans are a distributed factory producing new humans with a complex set of requirements subscribed in our 3 billion character long instruction set, with some probability of something happening in that process that results in the disorders that we study. On the left, we have estimates for how many times we've inspected that process via newborn screening in the US, and the current state of new adds of that process inspection each year. And it's actually a appreciable amount of data, which is something that we often accept as impossible in rare. And so we can do really cool things on it. So in the process stats world, we have a tool to help us understand such processes called a P-chart, which is a type of attribute control chart that uses a binomial model to calculate control limits that capture the variation in that process. And these are what's going to be shown on the right here. And to provide the visual, we've borrowed some data from a really cool study that Amy and her colleagues at APHL did last year. And we'll look at MPS I on the top and Pompe on the bottom. And so in this case, we're looking at each year as a distinct manufacturing lot of new humans that are tested, and we're seeing how our knowledge changes over time around what the actual prevalence is, and then what the variation we're seeing in those processes. And it's important, again, with this heredity as a process thing, that the variability we're seeing in each individual year is not distinct. It's actually a collection or a build on the variation we're seeing in previous years. So we've thrown up here the whiskers for the 95% confidence interval that would that show like sort of the normal way of looking at this stuff as distinct chapters, a collection of distinct chapters of a story, rather than looking at it as an evolving story. So the big takeaway here is that, again, every time we take a look at data, it's really just a snapshot in time that we're using to project or hypothesize some sense of truth. And it makes sense that as time goes on, we have additional information available, and we'd really be fools not to use it. So I guess that's my main message is like definitely look at the data and assume that we are some amount of wrong today, and that by doing the good work that we're doing and looking around the room, this kind of meeting, we can try to get less wrong over time, and that really benefits the families we serve. Thank you.
Thank you for all our speakers. So before we actually open the session for questions, I also would like to thank the supporters of this program, including Takeda and Chiesi. We have microphones at the back of the room, and they're going to walk around when there is a question. Yeah.
So if I look at your numbers from the newborn screening, why does not transfer this now to the reality? So that would mean something about 20,000 Pompe patients for the US. Is that number not still too high? So what is our caveat here? That the newborn screening numbers are not transferring into a clinical reality of the numbers?
Yeah, so I think newborn screening, this is one of the cool ways that it's enabled this evolution of knowledge. So there's a cohort being followed at Duke University that Aaron Huggins in the audience here has presented on. That's showing distinctly that every single one of those patients has detectable features that are uniquely assignable to Pompe, even the ones that have a genotype that is the homozygous for the leaky splice site variant, which we would imagine is the most mild presentation. And previously, we had questioned whether there's even disease present in that situation. So we're on a path now in the US to move towards 40x diagnosis, but we need to close that gap worldwide, because these are all patients that could benefit from treatment, and that work can kind of contribute to like what are the different modalities in process to jump in, and what is the appropriate treatment for their progression of the disease. But those numbers are real. We're that bad. We are that bad without newborn screening at diagnosing.
I might add, though, that the cases detected through newborn screening are going to be highly dependent on where a program sets its reference ranges. And so there are numerous programs within the United States who have actively chosen to set their reference ranges in an effort to focus on infantile onset and not late onset. So I think the numbers, we always have to caveat the numbers that we see from newborn screening with what is being targeted by the program, and there may be differences there.
Yeah, I would also add that the newborn screening is an ongoing process, so the cutoffs for the test do vary and will change with time. So in the beginning of newborn screening in New York, we had quite a number of referrals, and the incidence seemed much higher, but now the number of referrals has actually come down. So the cutoffs are really important, and the case definitions of those patients is very important. So I think that'll settle down and we have a clearer idea going forward what the true incidence is. And of course, by following these patients over time, we get a general better sense of if these patients will actually develop late onset Pompe disease, because clinically the patients were not diagnosed for a long time. So patients would have symptoms and would not be diagnosed for over 12 years or more. And so obviously this will make a big difference for those patients, but we still don't really have a full sense of that yet.
And those numbers are conservative for the reasons that Amy and Dr. Krohn just shared.
Mm-hmm.
Let's take another question. Any more questions from the audience? Can you get them? Turn the microphone on, please. Is it working?
Is that better?
Yeah.
Okay, awesome. My question, I guess mostly is Dr. Krohn, based on your talk, thinking about the patients that show up on newborn screening with a pathogenic variant and then like a VUS.
Yes.
So if those patients have a deficient confirmatory GAA, is that enough for you to call those late onset, or would you consider that still at risk for late onset?
I consider them at risk. We actually are really defining the patients. So we do enzyme assay at the beginning in the first week of life, but then we often will confirm it at about a month of age because there can be some variation. It's a little bit unclear. If you have a pathogenic variant, yes, that's one, but the VUS is clearly undefined, and we're finding that a lot of private mutations are occurring in the patients. So we don't want to, as long as the biomarkers are negative and there's nothing really to see on the patient, then we don't classify it. We consider the patient to be at risk and continue to follow the patient. So we have quite a number of patients we're following quite closely, and we'll see over time how they end up being.
With the clarity that we do have at least one biomarker that's already differing from norm, which is their enzyme activity level.
True.
Can I ask a follow-up question?
Sure.
You mentioned the patients that had a normal cardiac workup at baseline, but then later on, about a few months later.
Yes.
So for those patients that maybe don't have the IVS variant or have two VUSs, those would be considered essentially at risk for late onset or infantile onset?
Well, they could be. So what happened with this patient was a NICU admission. The patient was 26 weeks at birth, so they didn't actually have a chance to develop the cardiomyopathy, which develops usually in the third trimester. So that was the specific case. But we have seen a few cases where the cardiomyopathy is not present at the initial evaluation.
That's a very, very scary thought for me
Yes.
in the newborn screening space, since we've just started in North Carolina.
Yeah.
Very interesting. Thank you.
I think.
One last question. Could you take the microphone?
Hi. So I know the follow-up of these potential late onset Pompe disease patients is a big topic, and this has started with the, asymptomatic or however you want to call it. But are you finding difficulty getting insurance approval for these kind of follow-ups that you'd like to do?
We have not. We've been able to get Hex4 done on every patient, so whenever they're seen, we get them done in CBK. So we haven't had a major issue. The major issue is getting formal, more PT evaluations done, but we can use early intervention for these patients. So, but we haven't had many roadblocks to following these patients. I think the hardest part is making the parents maintain engagement so we don't get them, so they're not lost to follow up. And so that's important, and we work with the pediatricians in the local area to try and make sure that doesn't happen.
Great. Yeah, it does seem like, based on previous talks this week, that the PT follow-up would be extremely important.
Yes.
There are no other questions for Dr. Mageva. I want to ask something. So as the technology gets better with the tandem mass spec, and then the actually finesse to measure the biomarkers is also improving. So is there any correlation with obviously clinical typing is important for multiple disorders like Gaucher disease. So would there be a correlation between clinical types, when we severe versus less severe patient for the biomarkers?
I think from the newborn screening platforms and sorry, can you hear me well? The platforms are mostly screening. So at the point of the screening, you would like to identify the disease regardless the clinical form they are manifesting. But eventually in the confirmatory tests, the follow-up tests, then you can eventually through specific biomarkers that can be as high sensitivity, specificity, and a predictive value that eventually you can use for confirmatory and determine eventually clinical forms. That is still to be done, a lot of work. I think other individuals are here working on that. But I would say that from on the confirmatory level of the test, that will be important to use those biomarkers to correlate with clinical forms, and then make management decisions from then on.
Okay, thank you for coming to the session, and this is going to close our session. Thank you very much. Have a great day. Thank you.